Welcome. I'm Mary Marabelli, Senior Vice President here in the U.S. at HFMA, responsible for our corporate strategy and our growth plan. And today we're going to talk about value-based care and the journey we've been on here in the U.S. Today I'll be sharing with you four things: the basics on how the U.S. health system is funded, the mix of payers that we have, the amount of gross domestic product we spend on healthcare over the years as well. Then we'll talk about the emergence of paying for value as a mechanism to reward outcomes and not pay for activity, traditionally known as fee for service. Then we'll talk about the highlights of HFMA's Value Project. We'll share our research and some of our key findings. And lastly, we'll talk and give you a preview about what we've learned, what we think will happen in the near future, and the groundswell of awareness that we see that the current sick care system and funding it in the long term is just not sustainable. We will spend most of our time discussing the current and future state of the value-based care journey we have been on here in the United States. So let's start with a brief snapshot of the U.S. healthcare system and its funding sources. In the US, we have a variety of different organizations that pay the bill. The biggest payer of the bills are private health insurers, health insurance provided by employers or purchased directly by consumers. Medicare is our federal government as a payer. Medicaid, the next one, is a state-funded program with support from the federal government. Our Medicare program is funded through our taxes, the tax base. Medicaid is funded at the state level through state taxes and is also supported with additional monies from the federal government. And that's the major payers that we've got in the country. Now, each of these payers has a variety of rules and regulations to be followed, which here in the US leads to a highly complex system of payment. What about our growth in spending? Well, given the continued growth over time, it is widely recognized that this type of spending is not sustainable for us over time. So given the increase in spending, questions began to be asked. What are we paying for? Are we paying for activity, or are we paying for positive outcomes, healthy outcomes? Hence, the conversation began on value-based care. So the journey began, and our healthcare providers have really learned how to be resilient with one foot on the dock and one foot in the boat, really reflective of a system that is in transformation and is in flux. And then we struggled. We struggled to say, what do we change? Is it better that we change clinical practice first to get our folks healthier? Or do we change the reimbursement and payment mechanisms first? Which approach would help slow down the spending and produce better outcomes, better healthy outcomes, provide really outcomes that are considered a reflection of value? So what did we do in the US? Well, we did both in our quest for value outcomes. We started with outcome measures that focused on preventing harm within the walls of an acute care setting. So these measures were a mix of process measures and outcome measures. So one of the first things was, is there a process in place, for example, to rapidly treat a patient showing up in emergency with a potential stroke? And if there was a process in place to get them the medication that they needed, did they have indeed a positive outcome? The first tranche of measures also included hospital-acquired conditions and hospital-acquired infections. If a hospital performed well, then for every single Medicare payment, they received additional payment. Conversely, if they did not perform well on those measures compared to all other hospitals around the country, then every Medicare payment they received was reduced. They were penalized. So once hospitals and health systems got accustomed to these measures, then new measures were added to prevent patients from returning to the hospital after 30 days. And why did we do that? Why did that show up? Well, what was happening was patients were discharged probably before they were stable and ready to be discharged to home or another site of service, because the number of payment days had run out. And so what would happen is patients would get discharged, and within days, they would be right back in the hospital for another admission. So this rule was put in place to avoid hospitals from discharging patients before they were ready to be discharged. And the outcome was a good one. It was better for patients because they were stabilized and discharged and had a positive outcome. As we continue, albeit slowly, the focus now is transitioning to preventing the preventable. Efforts here are more focused on controllable components, such as some of those social determinants of health, and a variety of prevention efforts that are really focused on high prevalence diseases. Things like asthma, stop smoking, maintaining a good blood pressure. And this type of incentivization has moved beyond a federally only focused. Now what we have, state programs and just about all of the private insurance companies have implemented some form of value-based payments, all in an effort to keep people healthy while reducing the total cost of care. In summary, we've got a long ways to go to achieve true value-based care, to really move from volume to value, to focus on prevention, to treat smart, and to integrate care amongst so many providers. And that's why interoperability is just so important to us achieving this goal. So 6 years ago, HFMA really knew that the shift was happening, and we knew we had to support our membership. And so back in 2016, we published the Value Project. And that shift that has been happening here in the US really evolved into multiple value-based models. Since experimentation with various models began, a variety of value-based payment models have emerged. And one hospital or health system could have all of those types of programs in place that you see. And as you move from left to right, the risk really increases, but the rewards for doing well in those programs also increases in tandem. What we would tell you is the transformation has been paced. Most healthcare executives would say that finding models that work is happening, but perhaps one size does not fit all. This is a report from HCP Plan done in 2022. This is a group that evaluates the impact of various value-based care models and their adoption. The headlines are that 40.5% of payments still are not linked to quality or value. The other side of that equation is that 60% of payments are somehow linked to quality and value. What we see is that almost 20% is still fee-for-service. However, it is linked to a quality measure. And the remaining of payments that you see on the other side are a mix of many, many different payment models. And what that really means is that the focus has shifted to payment for a defined set of outcomes. So as leaders in the healthcare industry and in the finance industry, we have been watching this transformation carefully on behalf of our membership. The Value Project was born to help healthcare organizations really understand the types of capabilities needed to perform well in a world of value-based payments. Strategies, tools, and trends were documented, they were validated, and this report is actually available to any of you at hfma.org. There were 4 capabilities identified as vital to create a value-based, focused organization. Those four were people and culture, business intelligence, basically analytics, performance improvement, and lastly, capital and risk management. So when you look at this grid, on the top of the grid, various payment models were outlined, from fee-for-service on the left to full capitation, which is basically one fee given to the provider per month for every patient enrolled. And that is the model highest on the risk and reward spectrum. A tool was created allowing participating healthcare systems to evaluate their current capabilities, determine the payment models they wanted to aspire to achieve, and then outline potential actions really to get them there. Now, 6 years later, we are updating this framework to focus on a new continuum, one focused on keeping our populations and our communities healthy. We call it the cost effectiveness of health. To do this, we identified 4 domains, knowing that countries around the world have to adopt the model to meet their needs. The first 2 domains should look somewhat familiar. They reflect much of what happens today. Keep patients safe while providing transactionally focused services, to keeping patients safe while they're in our care. Then we move actually to keeping patients out of the hospital and keeping them healthy from A to Z, what we frequently would refer to as the health economy. Refreshing the value-based model with keeping people healthy as the ultimate goal meant we would have to update the capabilities needed to achieve health for all. You can see the 6 capabilities noted here. What is needed and what is measured has morphed for us to add in community integration, actionable insights, affordability, health measurement, and frontline clinicians. In the new tool, each of these capabilities is defined and the characteristics of each outlined. An assessment tool was also created to evaluate an organization's current position and then allow them to determine where they'd like to go as an organization. And then we outlined what to do when moving from one model to another, from one domain to another, and it is outlined by the various capability categories. This is still a work in progress for us at HFMA. It needs testing, it needs normalization, and it needs voices from many different constituencies to help us improve the model. Now, one of the most interesting pieces that we wanted to share with you from the original value project actually comes to us from the airline industry. While you might be saying, what? The airlines have actually faced many of the same challenges as we have and do in healthcare. The airline industry faced many challenges in terms of pricing, service, capital needs, customer service, and labor challenges. And they responded to the environmental and cultural challenges presented. They worked on cost containment. They worked on revenue enhancement. They worked on consolidation to gain scale. And we start to see that, we've already started to see that here in the US in healthcare. Well, what are the lessons for us from the airline industry and their transformation? For the US, well, we continue to rely on federal action, policies and regulations on payment and paying for value. We already see the emergence of many low-cost alternatives. Walmart, Amazon, Walgreens Boots, CVS, and other consumer-focused companies have entered the marketplace aggressively with lower prices, good quality, and much more convenience for the consumer. We also believe that we're going to see the commoditization of common procedures and their pricing. We see it now with independent, free-formed imaging centers for MRIs and CT scans. And we know our members are learning to diversify their revenues. They're learning to embrace innovation and increase demand in some areas while decreasing demand in other places in their organization. There was certainly a lot to share about this journey the U.S. is on to value-based care and the cost effectiveness of health. So let me summarize for you. We've seen the mindset change to value-based care, and we think it's getting actualized in a host of different ways and different models. And we think that will continue. We really haven't seen one model declared kind of as the winner. We also think that progress is paced, and it's going to continue to pace because it's difficult to do wholesale change in really complex systems like the healthcare system. We also think that more real-life examples of where it's worked are needed and helpful because those examples give us really great data and analytics, and we're beginning to understand which medical conditions are easiest for us to package up for value-based care pathways. We also do think that risk needs to be embedded into these models. And we think that is true because risk helps to drive new behaviors and new measurements that might not have been there before. And lastly, we would say to you, we don't have all the answers, nor do we think that this is easy. It really requires courage in leadership. So thank you for your attention. I hope this spurs for you some thoughtful consideration of what's possible on this quest that we are all on for better health for all in a value-based care world. Please feel free to reach out to us. I can be reached at mmirabelli@hfma.org. So please go forth and build value. Thank you.